Multiple myeloma. It is a disorder of plasma cells which are the immunoglobulin producing cells. Now, multiple myeloma is a disease of the elderly person above the age of 50 years. And as I told you, the plasma cells are having uncontrolled proliferation. But what is specific thing? There is a monoclonal expansion of the cells, and that's why they produce immunoglobulins, increase in IgG or IgA or kappa or lambda light chains. That means they produce lot of immunoglobulins. But point to be noted, although there is an excess of immunoglobulin is there, but these are all useless immunoglobulin. What is significance? I'll discuss very shortly. Now, how does the patient present? The clinical features. Patient may not have any symptoms. Few patients are totally asymptomatic, but otherwise, the most common presenting symptom is bony pain. It occurs in around 70% of the cases. Now, why the bony pain occurs? Because in these patients, there is increased activity of osteoclast. And excess of osteoclast, they lead to bone resorption. So, that lead to lytic lesion in the bones, which we can see by X-rays. And the most common site of bone involved is vertebra. And that lead to low backache. Second most common site is ribs. That lead to pain in the chest or in the thorax area. Now, what else? Because excess of calcium is coming to the blood from the bones. That lead to hypercalcemia. This is a very important feature of multiple myeloma. As hypercalcemia is occurring, that lead to hypercalciuria. And that lead to formation of microcalculi in the tubules, and that contribute to renal failure. What else happened due to hypercalciuria? Polyuria occurs. Because why? As you know, due to hypercalciuria, the patient develop nephrogenic diabetes insipidus. That means these are tubules, and ADH act on the collecting tubule. Because of hypercalcemia, the tubules become resistant to action of ADH, and patient develop nephrogenic diabetes insipidus. Now, what else happened in this patient? As I told you, there is an increased level of immunoglobulin, and IgG is increased in 60% cases, A in 20% cases, and the light chains, kappa and or lambda, it in around 20% cases. Due to high amount of immunoglobulin, patient develop hyperviscosity syndrome. And that lead to blurring, and due to this blurring of vision, fatigue. These occur due to hyperviscosity. And one more thing, these light chains, they are filtered in the urine. They lead to benzone proteinuria. Now, one more thing. Whatever this light chain which are filtered in the urine, they get precipitated in the tubules and they block the tubules, which also contribute to chronic renal failure. And this is known as lower nephron nephrosis. Okay, so we got another reason of chronic renal failure. This was the first. Hypercalciuria was the first, and this is second. Now, this was regarding. Now, third point: patients are prone to infections. The reason being that although there is high amount of immunoglobulin, there is a hyper gamma globulinemia, but they're all useless. In fact, the actual good amount of immunoglobulin level is reduced. So, good immunoglobulin level is reduced, but the useless immunoglobulin is high. That's why patients are prone to infection, especially UTI and pneumonia. Recurrent UTI also contribute to chronic renal failure. So we got third reason of chronic renal failure. Then the next point is patient can develop amyloidosis, and amyloidosis also contribute to chronic renal failure. Okay, so we got fourth reason of chronic renal failure. Now, what else? Anemia is common in this patient. It is usually normocytic, normochromic anemia, and that's the reason why these patients suffer from fatigue and malaise. Now, what is the triad of multiple myeloma? Plasma cells more than 10% in bone marrow. Number 2 is lytic lesion on X-rays and M component. M component means there is increased level of immunoglobulin in the serum or in the urine. This is the triad of multiple myeloma. Now, what happened to genetics? There is a T1114 translocation. This is the most common translocation. But the second thing is 13q deletion. And this carries a poor prognosis, but this is the most common translocation. Now, what else we have in this patient on investigation? Now, first of all, what is the best initial investigation? Best initial investigation is serum protein electrophoresis. But what is the most confirmatory test? that is bone marrow examination. And if we get plasma cell more than 10%, that is highly, and these cells are CD138 positive. CD138 positive, they are the most confirmatory tests about multiple myeloma. Now, what else we get in this patient on investigation? The other thing, other than the hyperviscosity and hypercalcemia and anemia, other thing are you get pseudo hyponatremia. But ALP, alkaline phosphatase level, is normal. This is very, very important point. Despite extensive involvement of the bone, ALP level is normal because there is increase of only osteoclastic activity. Osteoblastic activity is normal, so ALP is not increased. Raised ESR is a classical feature. This is due to Roulet formation. Then anion gap is less than normal. Okay. Then we talk about increase beta 2 microglobulin level. This is the single most poor prognostic factor. Now we talk about how to treat a case of multiple myeloma. We use melphalan. We use dexamethasone or prednisolone. The newer drugs are thalidomide and bortezomib. Bortezomib is a proteasome inhibitor. Thank you very much for watching this video, and if you want to communicate with me, please send me your information via messenger to me, so that I can be easily accessible to you and can listen to you and solve your queries also. Thank you very much for watching this video. If you want to see my previous videos, you can see at our Facebook or you can see in YouTube also. Thank you very much.